I have two like big picture questions since I have such wonderful minds here in our virtual room. I guess one big picture question is, does anybody ever think that we'll have a trial design that would allow us to understand sequencing in RCC? So, I think these two trials were, again, we've all acknowledged they're very informative. They've been negative. They've told us, while we were all trying to continue, checkpoint inhibition, that's not, at least in a PD-1, PD-L1 continuation, it's not providing, benefit. But is there a trial design that would allow us to understand, how you sequence treatments after that frontline combination?
We've been designing trial based on progression on first line, etc. So that could inform, but to have an integration in the same trial has been difficult because there's a lot of, from the time of record 3 or 4, I forget, that Bob Motzer led, we see that a significant number of patients, up to 50%, don't make it on the second part for many reasons: rapid progression, change mind, standard of care change. But we do actually have one of the studies that still matter in renal cell cancer is PDIGREE. PDIGREE is over 1,100 patient study where, based on the response to nivo/ipi in intermediate and poor risk, you get cabozantinib, or not. And I think this may inform a practice. We're going to see data in the next year, happening. And I'm happy that this study, which is over 6 years old and the design 7 years started, have survived the time of change of the landscape so far.
Yeah, I think that's great. I think many of us are excited to see those results come out. I know you and Dr. Tianzhong have certainly, formed that trial through the cooperative group network, and look forward to seeing what that shows. Dr. Paul, you look like you have something.
Yeah, no, I agree. It's funny, like you brought up record 3, and it's sort of taking me down memory lane to all these, studies of sequencing that, we've seen in years past. I was thinking of the switch trial, which is sunitinib and sorafenib, and sequence with one another. And I think that, there's, certainly laudable goals in trials like this. But having said that, I think what we've learned over the years is, if we try to sort of restrict investigators to a sequence of A followed by B versus B followed by A, typically, there's just issues that you might face in terms of attrition, as you go from first to second line. That was one of the main lessons learned, I think, out of record 3 and out of switch. But, beyond that, there's also that, onus on the investigator to do whatever they feel is best for the patient. So very oftentimes there's poor protocol adherence as you sort of pivot into second and third line therapies. So I'm not optimistic about trials that involve switching. And frankly speaking, I think that a better resource allocation is into studies like Tony's defined, pointing this way because that's where he is on my screen. And also trials involving new investigational therapies and regimens. I think that's definitely the way to go.
So, Katy, if I may add to that really quick, just to say, also came to I agree, great comments. Just maybe highlight 1 or 2 efforts in addition to that. One is we'll see some kind of these questions, not really the sequence, I think, but probably kind of start comparing them as much as possible. I mean, there's a smaller study out of Houston, right? LAMP-AB versus Cabo, for example, right? So that study is ongoing. It will provide some, I think, potentially useful information as a smaller randomized phase 2. But then a larger study is not having the pure design of a switch design, but things like SPARK-11 that Toni and others are leading. And when you think about LAMP in combination with belzutifan, right, compared to Cabo, right, because you're really thinking Cabo is the standard second line option, if you will. I think that can be informative as well. So while I'm not particularly expecting to see it switch, I agree PDIGREE can get us there in a different way. I think other efforts, large efforts put together, can also help us to, keep doing what we're doing, how we are prioritizing the DVT TKIs by generating data in the settings where we feel that, you know what, this is the most robust data to support our choice as kind of the default plan. Although we also, I think all of us have the sense that, again, not everybody should get the same strategy of A followed by B followed by C. That's probably not going to be where we're going to be in 5 years from now, right? And we all already picking different agents depending on the patient in front of us. But I think the trial data that's going to read out might get us to be able to be smarter, hopefully, and how to decide. Anyway, I just want to give a highlight to those additional studies.
No, that's great. And, thank you for bringing those up, and we'll keep our eyes open for kind of all of these exciting studies, which I do think will be, again, also practice informing. And